As firefighters, nurses, and emergency medical professionals, we can lead extremely stressful lives. I know one of my favorite things to do to clear my head is to get lost on a trail somewhere, but I always bring the right fuel to get to the top, and that's where True Wild comes in.
True Wild is all natural and includes nothing but high-quality, handcrafted ingredients to help optimize your performance during any challenge in the great outdoors or in the gym.
With amazing products to help you enhance your energy, like motion, or recover your sore joints with their signature turmeric and curcumin blend, True Wild helps elevate my athletic performance.
Regardless of what kind of athlete you are, they have the product for you. Yoga, get your mind right with their adaptogen blend. Endurance athlete, get a delicious sip of their watermelon lemonade hydration complex.
Use the promo code 15WildWall for 15% off. That's 15 WILDWALL at truewild.com.
Stay wild. All right.
Are we rolling?
Cheers.
We've been rolling for 10 minutes.
Oh, 10 minutes. Cheers.
Here, Mike. Oh. Salud, gentlemen. That's that Doers.
There we go.
That's good. It's smooth.
Every episode, I think they should become our sponsor.
Yeah. It was a hallmark of all the pictures. That's what people were saying. So
I started buying it because you can get a handle for $22, and it's way better than I was drinking Walker Black. It's like $28 a bottle.
Mm-hmm.
At Doers, I'm like, hey, how is this better?
Yeah, right?
So, started drinking that.
go ahead.
All right.
All right.
Welcome to another episode of Holding the Wall. We have a special guest on with us today, Skylar Lyons. Thanks
Hey.
for being here.
Nice to be here, man.
All right, so today we're kind of going to start talking about EMT to RN. It's going to be part of our education series, our advancement in
Career advancement.
That's right, series. So going to be our first, or I guess our second guest for that series. Before we start into all that, I just want to see how you guys' week went.
Do you want to start first?
No, I have a lot to say, so you
All
guys
right.
start first, and I'll
All
get
right.
into my
Round the horn.
crazy
You're
week.
supposed to read me in on this one. So there's something I wanted to bring up.
Oh, yes, our PSA. This is
Yeah, our PSA. So at my ER, I guess it was 4 to 5 days ago now. I was more worked up about it the moment I texted you and I heard about this, but they got a pediatric full arrest, 10-month-old, and it was a scoop and run by PD. They didn't wait for medics. So there was no red phone or ALS phone. There was no notification. As I heard it, I wasn't on shift that day, but it really affected my my coworker a lot that she was texting about it.
Yeah.
And so I wanted to bring it up. From what I heard, they just heard sirens and then they stopped. And then they heard more sirens. And next thing you know, through the ambulance bay doors, you just hear, somebody help me. And you just see like this little football that they're trying to do compressions on, but not effectively because they're running and, you know. And so the ER was caught with their pants down.
Oh, yeah.
And it was a scramble to tube, and no one could get a line, and people were trying to get, I don't think they even were able to get an IO established. It was just a very high-stress, unprepared environment, and there was a negative outcome. The child didn't make it. My coworker that brought it up, she's a parent and a mother, and it affected her a lot because I think she had a child the same age. And then I know the charge nurse at that time was very upset, couldn't get IV access. I just want to talk about scooping and running. I know that's, I think the last time I sat in on a continuing education class, that shouldn't be the practice anymore. Like, you want to work them up, get some good compressions in. I've had other coworkers where they'd arrive on scene and they'd see, sheriffs coming out the door or whatever, local law enforcement, and they had to redirect them, and they started working up the full arrest on the tailgate of the engine.
Oh, yeah.
So
it is an old school practice. So this is a big shout out for our, law enforcement brothers and sisters, but it's an old practice and we got to stop it. So I've even seen it in my city where this poor officer, he gets like every pediatric full arrest in our city. He just happens to be the first one on scene. When I first started, he did the same thing. Mom walks out, limp baby, little 4 or 5 month old. He grabs the kid, hops in the back of a patrol car, and they speed him off to one of the hospitals. The kid had a bad outcome, just the exact same thing. That job is an impossible job. They have to deal with so much, and they have to sometimes they're the first on scene for these EMS calls, essentially.
Yeah.
And they have very little EMS training unless they happen to be like an EMT or a paramedic prior.
Right.
So it's a very difficult situation for them to be in, but we got to stop it. Even recently, I went on a pediatric drowning, a little 2-year-old drowned in a jacuzzi, and the cop was the one who pulled him out, and he was running toward me, and he was like, hey, the ambulance isn't here yet. Let's just get in my car, and you can work him up in the back. I was like, no, stop. Put him down. And he's like, no. And we were like about to start fighting over this, and I grabbed the kid, I put him on the ground, and we worked him up. And we worked him up there for 15 minutes. And the PD was freaking out, right?
Mm-hmm.
You're like, oh my God, they're just sitting on scene with this full arrest. Like, what's going on? Every study I've read, all the evidence indicates that compressions are not beneficial, and they're not quality compressions in the back of an ambulance when it's moving, let alone in a patrol car when you're holding a child and trying to do compressions. It just doesn't make sense.
It's a good point to bring up. Like, it's in terms of all those kinds of situations. Number one, you're looking at two things there. Like you said, this is an undertrained professional. This is PD, not EMS. Even for us, like Ryan, you were mentioning, like, texting after this incident, your charge nurse was upset. Everybody gets upset.
Yeah.
It's hard for us to handle, much less somebody who's not medically trained. And then, getting quality compressions, good airway on kids, super, super important, because almost, drowning in a jacuzzi, there's an obvious sign, but making sure that somebody, if you have an unwitnessed arrest or you find a kid who's not breathing.
Kids aren't having STEMIs. It's all 10 times out of, not 10 times out of 10, but 9 times out of 10 respiratorily involved, right?
Yeah. So making sure that you have the time, like, absolutely right. Making sure that we're able to get those quality compressions, and then making sure somebody who knows how to do compressions and isn't in that fight or flight kind of thing where they're just like,
oh yeah,
it's like, no, allow for recoil. Let's do it. Yeah, it's faster on kids, but you still, gotta.
But that recoil is how the heart perfuses itself. It's the recoil that feeds the heart. So a lot of people don't know that. Like, that's why compressions, the compression itself feeds blood to the body, but when you actually allow good recoil, that's what allows the blood to actually feed the heart. So
you're not getting anything out of an empty ventricle.
Right. If you're just going crazy.
And
I get it. It's high stress, and it's a scary thing to be handed a limp baby. And then have to sit there and wait till fire or EMS arrive. But it would have to the qualifiers for that to be a good decision would have to be like the hospital was across the street.
Right.
That is it.
That was a scenario
almost solely it
that presented itself when I was talking about it with my coworkers. But like, we don't know. I don't know.
But just about any other time, it's just not. It's not the best. It's not what is in the best interest for the patient. And it's hard for other people who aren't medically trained or understand these little intricacies to know that, hey, what's going to be best for this person is to not be at the hospital right now and sit on scene and get the best care and see if we can get pulses back. Because if we can get pulses back and the patient's perfusing on their own, then we can start transport, and then all these things happen. Like, you see with adult patients that compressions in the back aren't beneficial. I think the return rates are for patients who are transported while CPR was in progress manually is like
it's low,
next to zero.
So a lot of places are mandating the auto pulses.
That's what we moved to. Like, we don't move our patients in the ambulance until we have the auto pulse on.
You're talking about
because they're so effective.
Like a Lucas? Is that
yeah.
Really? In the ambulance?
Yeah, so we have them as well as at our fire department.
Oh, wow.
Where we have the auto pulse. So we have like a high performance CPR committee that has implementing this like specific design of how we run cardiac arrests. And we have a certain team that implements the auto pulse, hopefully usually within the first 5 minutes and all this stuff. So we have like it very regimented. We practice on a regular basis. It's one of those things like my captain always says it's the structure fire of EMS calls. Right. And I think that's kind of a good mentality to have when you're running these calls, because they are the most critical. This patient has already died and we're trying to get them back. So.
And if you're out there listening to this and you don't know what that device is or does, I would suggest YouTubing a video of an auto pulse or a Lucas device. It is
or geezer squeezer.
Yeah.
Hey, that's what North Vegas called it.
Yeah, if you want,
is that what you got?
If you just all you have access to is Urban Dictionary.
Yeah, like Skylar said,
but
look that up. If you haven't seen it, or if your department or whatever agency you go to doesn't have them, oh man, look that up.
It does not look comfortable.
It looks like a medieval torture device.
Yes, it does.
And that's like the autopulse is the good one, where it's the constricting band. I was in Dubai at a medical expo once, and they had the old school ones where it was almost like a boxing glove on a
It's
piston.
the Lucas device. Yeah.
Boom,
Yeah.
boom.
Did they have the music? Dun, 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 dun,
It
dun.
looked brutal, and I don't know, but they're very effective. I had a Zoll rep come out, and she was talking about the benefits of auto pulse when they were trying to sell them to our department. And I was like, oh man, these things are amazing. Like, I was listening to a podcast, and they were talking about how because the auto pulses are so effective, they're having patients who are perfusing so well that they wake up while still in VFib.
Ooh, I have a really good story about that, actually. This is it's kind of tangential, but I feel like that kind of embodies this.
That is this podcast.
That's
So
what
by
they-
all
yeah.
means,
Embodies
Go for it.
the nature of the room. No, I remember I had this. I was a EMT working at a big trauma center. It's a level 1 trauma center now. And we had this patient come in, and I was fairly green still. I would say only had like maybe a year and a half of experience, not a whole lot. Definitely couldn't tell like a 12 lead from a thing of tangled fishing wire. There's really not much in my department, but I knew more or less what one should look like, right? And so we had this patient come in, and the medics had kind of disregarded her, and she was very ornery, and she was kind of, soiled and all that. But she was saying that she was short of breath and had chest pain. So, they drop her in a room, and I take it upon myself to make a run at just doing a 12 lead. And I do one, and I finish, and I look at it, and then I look at the patient to make sure my leads are in the right place. And then I look at it again, and I was like, I should probably show this to somebody. So
Yeah.
I walk up to this doctor, and I was like, hey, Steve, like, I did this EKG. This patient has chest pain. What is this? And he's just like, oh, shit. Like, he's like, where is that patient? I was like, they're in room 8. He's like, move them to one of the trauma rooms now. And I was like, okay. And so I rushed this patient over, put her in a trauma room, and I didn't know what was going on, but I knew enough to grab a stool to stand at the side of the bed with.
right?
Yeah.
And the doctor comes in holding the EKG. A bunch of people come in behind him, and he just looks at the patient, and he says, if your heart stops, what do you want us to do? And the patient said everything and died. And I was I was right there.
Womp womp.
So I was right on it. Like, I mean, I just immediately started compressions. Like, just check for pulse, no pulse, here we go. And it only took like maybe 10, 12 compressions, and she was awake. She grabbed my wrists and pulled me off her chest and died again. So
That's what she gets.
I know. What a rude person.
I know.
So
Get
I
your meat hooks off of me.
put my hands on her again, start pumping again. She wakes back up and goes to rip me off again. And I said, stop grabbing me. I'm beating your heart for you. And she just put her hands down and stared at me. And it was the weirdest thing. Yeah. So obviously her potassium was off the charts. She had missed dialysis for 3 weeks or something because
Oh
that's
my
what you do
God.
when you don't want to go to dialysis because it's real far.
Oh yeah, that's such a
very
pain.
inconvenient.
Oh, they're
Yeah.
Yeah, that thing that
cold in
keeps
there.
you alive. You should probably do that.
Yeah. She ended up having totally good outcome. That was just like
Really?
yeah.
Good.
No, she went to the ICU and was discharged, I think, within 48 hours. It was like unbelievable. She just
Dang.
she got her dialysis.
So I
That's
think
a
that's
good
a good
segue
to my
to-
week.
Josiah, tell me about that
Oh
STEMI
my
story.
gosh. Okay, so I worked 1 day of overtime this week, so I worked a 72, and it was so busy. I was just like exhausted by the end of it. All I wanted to do this 4 day was like chill, and I ended up having to teach PHTLS for like 2 days. So, but anyway, so my first day this was back to back to back. It was a rollover TC with a trauma patient, criteria. From that, we had a teenager GSW killed himself, like family outside. So we had to like mitigate that scenario. And then that was followed up. I finally get into the shower, getting ready for bed. Call comes out, baby not breathing. I was like, fuck. It was like a terrible first night. I was like, I'm earning my OT tonight. And then later on that evening, we get a call for chest pain. Guy, it was like textbook. I was sleeping, woke up, chest pain, substernal radiating to my arm. He was cool, pale, diaphoretic. I was like, okay, this feels legit. I was like, oh, in our city, we have a lot of people who visit and try weed for the first time. So like eat edibles and eat too much. And I was like, okay, did you eat anything today? And he was like, no drugs, no alcohol. I was like, okay, let's do a 12 lead. And it popped up STEMI. But when I was looking at it, I was like, man, I am seeing like only a millimeter of elevation in 2-3 AVF. I was like, hey, let's do a right-sided. Do a right-sided. Nothing pops up on the right side, but V1, V2 comes back, and there's quite a bit of depression. I was like,
Ooh.
all right, so let's try a posterior.
Yeah.
So for anybody who doesn't know, our 12 lead, our standard 12 lead is only looking at that left ventricle. So if you see elevation 2-3 AVF, it behooves you to move over V4 to the right side, same landmark as far as mid-clavicular line, 5th intercostal space, but you want to run a second 12 lead to check the right side. Well, with ST depression in the septal leads, lead V1 and V2, you should check the posterior, which is 7, 8, 9. So you go under the scapula and you put leads there. We run that third 12 lead, and sure enough, we find the elevation. Wow. And he's having a big old MI, posterior wall MI. So we start transporting the hospital, and we give all our meds and stuff, start 2 lines, and we transfer care to the hospital. I walk the doctor through all our findings as far as like searching for this MI, and she tells the guy, hey, we're going to bring you to the cath lab. You're having a heart attack, all that stuff. And this guy was really nice. So, we'd calmed him down. I was like holding his hand half the way to the hospital. So I said, let's call him Mike. So I was like, hey, Mike, it was really nice meeting you. And I shake his hand and he says, I'm scared. And then his eyes roll in the back of his head and he dies. And I was like, motherfucker.
Impending sense of doom.
Yeah, I look up and he's in V-fib. So I lay him down. I start doing compressions. And I tell my partner, I was like, hey, code blue, grab the crash cart. I don't work in the ER, but we were just helping out the nurses. And sure enough, they shock him, and he pops right out of it. And he's like, my chest hurts. I was like, I'm going to leave now. So I leave, and, I guess a couple days later, so it was maybe like 2 or 3 days later. So I worked my normal shift, and the day I got off, he went to the station I was working overtime at, and he was like, hey, did you run a call on me the other night? And the firefighter there texted me. He was like, hey, did you run a call on Mike? And I was like, yeah, I did. He was like, he came by the station. He was like in tears saying that we saved his life and he's doing better now and everything is all cleared up. So like that was the first time I got feedback from a patient that, was that critical and swung by the station to say something. So that was pretty cool.
I must say there's no better way to go than dreamy Josiah just holding your hand and just like
caressing your hand one last time.
If we could all be so lucky.
And the angel came, but he wasn't as good looking. And then when he went out,
first steps into nursing intervention, man, caring touch.
And then when he walked away, it was even better.
One thing from Dr. Nolette, and that was the gentle.
The worst is over.
Oh yeah.
That's great, though, that you got that kind of feedback from the patient. That's something that's really missing in our industry. We very rarely get to see the impact of what we do on the patient because it's like, here you are, you're dying. Okay, we do this. You go to the ICU. Who's next? It's not something that we end up even really thinking about all that much. Like you do, I feel like at the start, but then you're almost just so overwhelmed by the amount of sick people you see in critical cases that eventually you're just like, okay, this is just a routine thing. And then when they come back somehow and they're people and you remember that what you do really matters and you get that kind of feedback, it's really touching. It really is.
So Ryan said that as well. He was like, oh man, I've never kind of gotten that closure from a call before. And that's one of the things, like I've had partners in the past who like they seek out further information and stuff and like what happened to the patient after we left them. I never want to know because I know I did my job the best of my abilities. I gave Passover, and when I left, they were alive. That's good enough for my conscience. Mm-hmm. The fact that he came back and he was super appreciative, like, oh dude, if I would have been there, I'd have cried like a little girl. Yeah. Like it was a cool thing to hear. So that was my first day.
Yeah.
Hold on, before we move on, I want to talk at some point. I've never done a posterior 12 lead, so
yeah, I'll come back to that because I've had to do it multiple times, and I've had other like paramedics who are like, "Is that a thing?" Like my captain, I was during probation. I'll just get into it now. Fuck it. This lady was having the most benign chief complaint. Like I was irritated because it was in the middle of the night, and she's like, "My fingers are tingly." I'm like, "God damn it!"
Now your back's gonna hurt.
Yeah, exactly. And then we do a 12 lead and pops up STEMI because I was just wanted to cover my bases. I was trying to AM air, and I was like, shit. Okay, let me look at this. And I was like, okay, well. It's saying posterior wall. I'm seeing depression in V1, V2. Hey, like, let's do a posterior wall just to confirm. My partner starts putting him on the back, and my captain looks at my senior firefighter who's kind of like training me. He's like, is that a thing? Like, did he just make that up? He's like, it's a thing. So we did it, and sure enough, she was having a STEMI. I was like, oh, all right, shit. Well, I guess we're going. So okay. So for the posterior wall, I take 4, 5, 6 off. And I put it, we turn it to 7, 8, 9. So when you get your printout, you cross out V4, V5, V6, and you write V7, V8, V9. It's in a straight line on your back just under your scapula. So that's how you do a posterior wall MI.
Okay, and then what?
Oh, yeah, 12 lead, excuse me.
And then what? I mean, if you don't avoid the scapula, what does it look like? Like, let's just say you.
I go about a third way down on their back. That's usually, I don't palpate for the scapula, I'll be honest. I usually follow the line of V5 for my normal, and I just go on the back.
Just wrap it around.
Yep,
Yeah.
exactly.
Okay. Yeah. Continuation. You could just leave the stickers on from V4 through V6 and just go V7, V8, V9 where you think they are. That way you don't have to do as much guesswork in terms of which, I guess, latitude you're at.
Yeah, right.
It's probably
That
not the
makes
right anatomical term, but latitude makes sense.
So like I said, that was day 1.
Yeah.
Day 2, it was another super busy day. And we get a call for big dude. So he calls out for a near syncope. He was like, I was folding my laundry and got dizzy. And I'm like, yeah, he looks a little cool. He looks a little diaphoretic. Something's probably up. Okay. Maybe he didn't eat or drink enough today. And my partner is the one doing he's patient care. So he's doing his assessment, and I'm putting him on the monitor. And I finished my last lead, and I looked down, and it says, whop. Big old VTAC right on the monitor. I was like, oh, shit, VTAC with pulses. And I've only had a VTAC with pulses, I mean, a small handful of times. Like, counted on one hand, where they're still alive, sitting there talking to me and hanging out like it's nothing.
And they don't know yet. And so you're like, so how you doing?
Yeah.
Oh, yeah. I was like,
Why do you keep asking me how I feel?
Yeah.
how do you feel? And he was like,
Why do you keep
I
looking at me like
feel kind of cruddy. I feel dizzy and weak, but I was like, oh, okay. So my partner did a really good job. I think as a team, like, we work really well together, my crew. But I was like, sir, you're in a very deadly rhythm right now. We're going to start moving a lot faster. I don't want you to get nervous, but we're going to have to do a bunch of stuff, okay? And we just start cutting off his shirt, putting on pads, doing all that stuff. And we were trying to figure out, like, okay, this guy is at least 450.
Oh, my goodness.
And should we stand him up and put him on the gurney in case he codes after we cardiovert him? Or should we cardiovert him, and if he codes, have to try to pull him onto the ground and work him up?
That's a lot of dead weight, too.
Okay, as of now. So we just, like, stood him up real fast, put him on the gurney, and we're like,
Okay.
we're good. Okay, so we loaded him up, and
Nice.
we cardioverted him, and he converted after the first cardioversion, but we gave a little Versed beforehand. And I said, this is going to kill your pain, but it's going to help you forget it later. Oh, man, when we cardioverted him, he was like, screaming. And we converted, and we're like, okay, thank goodness. Did our other 12 lead and IV and all that stuff. But he was like, please just don't shock me again. And I was like, we don't have to. You're doing a lot better. So he did just fine after that. But it was one of those calls. I was like, please don't die.
That's a good
And then
one.
my third day.
Dang.
It was one of, like, those busy shifts where I think I transported code 3 like 7 or 8 times. That's transported code 3. Like, I'd been last month without one.
Dang.
So another large patient went into a gas station to use the restroom. It wasn't bolted down. So when she sat down on it, she fell off, and she hit her head on those metal side rails.
Mm-hmm.
Well, it gave her a brain bleed.
Wait,
Just
the
from
toilet
whipping her head on it. I was
it
like,
toilet seat or was it toilet?
the whole toilet wasn't bolted in, so it tilted as soon as she sat down, and she fell and hit her head. So when we walk in, I was kind of thinking it was BS, because she was, like, yelling at her friend to go pay for the waters or something with the credit card, and she was, like, spitting blood on the ground. I'm like, why are you acting like an animal right now? Well, it was a weird thing to notice, but the way her left foot was down, like, it was like all her weight was down and her foot was to the side. Like, I was like, man, that looks really uncomfortable. Like, what's going on with that foot? I was like, ma'am, can you lift up your leg? And she, like, couldn't. And I was like, okay, squeeze my fingers and complete left-sided deficits. And I was like, where'd you hit your head? And she hit it on the right side. Mm-hmm. And I was like, something's up. I was like, are you talking okay? And her face was kind of like, she gave me the stink eye. I was like, oh, shoot. I don't know if I don't know if she stroked out and that's why she fell, or if she fell and now
The
she's
trauma,
having some kind of head bleed. But I was like, let's go. Another code 3. And sure enough, she was having a brain bleed. I was like,
Wow, man. It's a bad night.
So
Yeah.
So we didn't know is that Josiah was carrying a mirror, walked under a ladder, tripped over a black cat, and then went to work. Is that what you're telling us?
I must have, because my God, I was exhausted after that shift. But yeah, it was an exciting one, that's for sure.
It really puts into perspective the kind of differences between kind of practicing in EMS and doing it as like an ER nurse, because we see it now, me and Ryan.
Yeah.
from kind of a very different perspective. You guys have all this initial workup, really sizing things up, getting your initial assessments, figuring out what's pertinent, making good recognitions and going forward with that. But then once we get people, we're working on like a very different level of kind of information. We're working off of labs. Like I'm going to know what the potassium is. I'm going to know what the hemoglobin is. Sometimes they're both bad. I had a patient last week, their hemoglobin was 5 and their potassium was 8. And I'm like, crap. That's like, good. Yeah. But I'm like, I got a lot to treat right here. And in the middle of giving them 2 units and the whole like CBIT kind of treatment, giving them calcium, gluconate, insulin, dextrose, bicarb, they walk into my room and they're like, hey, your patient next door has a subdural, and so it's same kind of stuff where you're like, all right, I'm like, how's he doing? They're like, he's okay. I'm like, all right, I'm going to be here for another 10 minutes.
When it rains, it pours, I guess, huh?
It never seems to be easy, but, we like it. Otherwise, we wouldn't do what we do, right? Yeah. So that kind of stuff is good. And working off of the, you hear about the imaging later, but when we see the imaging, like, okay, I'm calling neurosurgery, I'm getting the patient transferred to USC, calling reports, we're raising the bed to a certain level to help reduce intracranial pressure, we're giving mannitol, there's all kinds of stuff that we can do, or hypertonic, normal saline. You got your choices depending on how old school your doctor is.
Yeah.
And, we don't really have a lot of say in that, but sometimes you can kind of hem and haw about it. I'm like, are you sure you want to give this? Like, I have the opposite effect of what you want. Like, I don't know if we should do it. And then
your voice just went up an octave there.
It's like, you kind of got to use that unsure, not like, because you go up to the doctor and be like, hey, you can't do this or your patient's going to die. I'm like, they're really like, hey, I'll, do it. And you can cause this like conflict. Just be like, hey, like this patient that you ordered 4,000 of normal saline for has pretty bad CHF. So I didn't want to run that in over an hour. Do you want me to like dial that back? You can kind of sell it a little bit. And those are different kinds of,
I tell the new grads you have to inception.
Incept. I use that too. Incept the physician. Yeah. It's a skill.
Yeah. Oh, for sure.
It's not just physicians.
Does the octave work, but does the Jay Leno work?
Yeah, you're going to have to titrate.
So before I forget, I think that would be a good episode. Maybe you could come back and talk about it. It was just lab values. For like EMS, we learn such little about lab values, but they're so important. And sometimes you do get them. So like that's super pertinent for us. Like it would be like, I keep saying behoove. It would be beneficial.
This episode brought to you by the word.
I know, right? Behoove. Word of the day. It would be beneficial, I think, for everybody to learn a little more about lab values and stuff.
Yeah, it's something that you can kind of, you use it to guide your practice once you have those initial things. Like a lot of ERs will have something called an I-stat where you can immediately, I don't know if you guys have that where you are now. You do? Mm-hmm. Yeah, we do not, but I've had it at hospitals I've worked at in the past. And it's great. It spits out a bunch of like, electrolytes, and we can get like there's another thing called a HemoQ where you can kind of get that really quickly. It's really
not
great.
Comprehensive, but we are using the point of care lactic acid.
That's
nice. For our code
yeah.
sepsis.
That's really, we do not have that, and we do so many. That would be such a great thing to have at our hospital.
We talked about it in our STEMI episode that it would be nice if we had those in the field. They work as easily as a glucometer. I don't know why we couldn't, just to confirm our sepsis.
Every time I ask that of any director, I get a very long answer that by the time they're done, my brain has taken a walk. It's like, so we can't do it for this and this. This lab is owned by this company, and this person doesn't want it. And this person, and I'm just like, this outweighs my interest.
Just say we can't do it.
Yeah, we can't do it. It's fine.
You know what I found out from a coworker that picked up like a per diem at another hospital? They have point of care troponin testing.
Really?
Yeah, I don't know if that'll be. I don't know if that's something. I don't know if it's something the field needs, but I don't know.
It's interesting. So we'll give a little taste of maybe a future episode, because troponins you have to take into consideration with a lot of stuff. So
that's right.
Yeah, with like a troponin, like 0.08, right? That's your cutoff for like considering MI. But that value changes wildly in terms of kidney dysfunction, and you have so many other things that can influence it. But if you have somebody who's on dialysis and has not gotten dialysis, their troponin is essentially worthless. You have to like clinically correlate their symptoms and their EKG, and there's so many more things to consider. So it doesn't just necessarily go by the lab value. There's a lot of like clinical correlation that has to come along with these kinds of things. So it's good to have these in the presence of a physician, because like I understand some of these concepts, but like not on the level that an ER doc does. So
interesting. Yeah. So is 0.08 something you guys learn in school, or is that something for your guys' hospital? Because I've seen other hospitals where it's like 0.035, 0.045, 0.55, that anything above that would qualify as elevated troponin.
There's a lot of different, I think, kind of standards hospital by hospital.
Okay.
It's one of those things where the cutoff is, I think, sometimes I don't know if you would call it arbitrary, but like different places have different levels of concerns for sure. Again, like I think it's mostly based on clinical correlation with things.
Okay.
Like you don't wait for a troponin in a lot of cases, even if you like have a point of care one. Some people are just direct to cath lab if you have one. It's I mean, I'm sure you guys have probably rolled people directly to a cath lab rather than stop in the ED and have the patient seen by the providers and do that whole workup. Just like no, we know this is a STEMI. STEMI in the field meets criteria. Go directly to cath lab.
Yeah.
Somebody does like a hand wave in the ED and they're down there.
You have the airplane guys just heading you down straight to the cath
Yeah,
lab.
essentially just wave you through.
All right, Mike, how was your week?
Well, you should have asked me that before I just blocked it out. But I know it was exciting enough that they made a movie about
Oh,
it.
really?
Yeah,
Wow,
yeah.
that's
It's for
impressive.
Bill Murray, Groundhog's Day. Just, routine. The most exciting one was he had this one kid, like 3rd-degree Indian burns. He had
He's
purple
just so
nurples.
Oh man.
But and even
Code
worse, we
3.
had to take him over to trauma because he had chocolate. He got chocolate swirly. So that was pretty much my week.
The same old.
Yeah.
Nice. What about you, Skylar?
Well, I did have that one that I told you with the low hemoglobin and the subdural came in at the same time. They're great, actually. I really, really enjoy critical care. So to go into my background a little bit, I met Ryan when we were working in a hospital in LA. Both of us started there as new grads, and the level of critical care was difficult given the amount of resources that hospital had to provide for critical patients. It was pretty overwhelming. Where I am now, my critical care, like if you have a critical patient, like a truly critical patient, ICU, you go 1-to-1. They'll maybe give you like an extra patient that's kind of like a hand wavy patient, like this guy needs a lac tray set up, like the EMT will do it, like you'll be just mostly in here. It's like, okay, great. So yeah, I really, really enjoy that. And then my roles at the hospital I'm at now include being what's called a sepsis nurse, which is me just scanning everybody who comes in for sepsis criteria and making sure that we have early draws, blood cultures drawn, lactate drawn, and then making sure that we do early intervention antibiotics, a monotherapy, a broad spectrum if indicated, and then making sure that we do an ideal body weight calculation to initiate fluids, and then we have these bundles that have to be done within 3 hours and 6 hours. It's all very like aggressive. It's great because like those patients, like septic patients are sick, and if you're the sepsis nurse, you're hopping in, you're involved in their care, and that's super fun. I really enjoy that because you're helping with outcomes, and with sepsis patients, like you hear a lot about sepsis in terms of like what interventions are useful. People want to give them a lot of fluids, this and that. Pretty much the most important thing with sepsis patients is early intervention with antibiotics. Early antibiotics save their life. So that's what's got the highest correlation with mortality, whether or not they're discharged from the hospital, And so it feels good to be in a position there where I can do that. So my week is great because now I'm in a position where I have more resources, I have more unique experiences, I would say kind of a higher level of understanding of my job than when I was a new grad, where I was just trying to survive every day.
Just task oriented.
And just this nervous sweat walking into work, like I can't do 4 ICU patients at once again. Yeah, no, it's much nicer. So my days are happy. You're busy. It's like we're all busy. It's not like we got into this industry to hang out and just kind of shoot the shit at the nurses station.
Yeah.
We work and we work hard, and that's great because we're doing what we like to do, and I still feel like I get that every week. So yeah, man, just happy to be doing what I'm doing. I really don't have a backup right now in terms of what I would be doing with my career.
I know. I was thinking about that too. I was like, ooh.
Yeah.
But it's cool to hear. Like we did a sepsis episode, but a lot of hospitals are being so much more aggressive with sepsis care, and I feel like when I first got into EMS, we were a little more blasé with these patients. And now we're recognizing how significant the mortality rate is and being a lot more aggressive with the care and recognition and all that stuff. So it's cool to hear, especially somebody who's participating in that team.
Yeah, it's good. It's just it's a long background that kind of got me there, but I guess I could dive into that a little bit. You guys were asking about how I got to where I am, like kind of the pre.
Let's rewind.
Yeah.
So Skylar was in our field as far as like EMS is concerned as an EMT, and then he moved transition similar to Ryan as far as becoming a registered nurse. So
my experience was a little bit different. I kind of started out with the same kind of aspiration where I was going to go out on a rig. I was going to go do everything in the field. That was kind of my thought process. And during my time in an EMT program, I volunteered in the emergency department. And I loved volunteering there. I thought it was really interesting. I got to the doctors would even talk to me just because I seemed interested, and they would explain what was going on a little bit, and I could see x-rays, and I was like, this is kind of fun. And then I learned that I didn't even know it at the time, that there were EMTs that worked in the hospital. And I was like, there's EMTs in the ER. And I was like, that's cool. Like, what do they do? And I was like, they're all in all the traumas. They're putting on splints. They're doing EKGs. I'm like, this looks fun. And so I ended up out of the program getting a job in that emergency department. And then I very much overstayed my welcome. I was there for about 9 years as an EMT, just not totally directed on what I wanted to do at the time. And, after about 5 years or so, I was like, okay, I should probably pull the trigger, do some anatomy and physiology, and probably move towards nursing, because this seems like a really good fit for me for life. And I was glad that I did. My wife, who I met in the emergency department, she was a scribe. I was an EMT, which is, classic Romeo and Juliet.
Yeah, classic love story right there.
Exactly.
Over Jell-O and turkey sandwiches.
Exactly. That was our first date. She went to med school in San Francisco, and I did nursing school in Santa Barbara. And when she finished, it was great because I had finished my nursing program while she was up there. We knew that we could go anywhere together because wherever she went, there would be an emergency department. So when she got residency in LA, it wasn't a problem for me to move with her, and we came here. And that's where I started my first official nursing job. But I started without any real history of experience to say, in terms of nursing experience. And I didn't really have an in because I didn't know anyone in LA. So finding a job as a new grad coming into a city is difficult, but fortunately for me, I found a registry agency that placed new grads.
Nice.
Except I signed a 2-year contract, and I was stuck on that for a long time. But it was nice because I kind of got to be like, well, I want to work in this area. I want to do this specific job. Like, if you put me in the emergency department, I'll be happy. And that was true. And then I met Ryan when we were both working there. I think you had no idea how little experience I had when we were training you, myself and our friend Corley.
Yeah.
And it's like, man, we were so green ourselves, and here we are, like babies training babies.
I was like, how do I get there? He's always taking care of the critical patients.
How do I get there? Wait a month and a half.
That's about right.
Yeah, you were there. You didn't even wait that long, man. You were like, with Ryan, we're like, okay, he's smart. Put him in the critical rooms. And you were. I remember talking to you your first night alone. It was like, God, you had this person on a heparin drip, and you were just reading the box, trying to figure out what the heck's going on with that. Because there's no good learning curve for that job. And I feel like that's true no matter where you work as a new grad nurse. It's a rough go.
But I want to tangent real quick. I remember from a nurse that I crossed paths with when I was an EMT, and he was a CCT nurse. Just that what we went through. He said there's no better way to learn or experience when that pucker factor, and that's what we got every night at that ER. Yeah. And so I just feel like,
it was Kegel's 24 hours a day.
Yeah, exactly.
There was no holding back. But yeah, the absolute best experience you can get is to just put yourself way over your head and swim. That's what we did, and you got to see so much. I mean, taking care of so many critical patients, chronotropic drugs were like Pez to me by the end of that. It was just so easy to titrate pressors, and I got so good at it, and I knew all the dosages and the increments, and it was crazy. And then coming out of that and coming to another hospital, I've been spoiled, I would say. Yeah. So now I have this amazing background where I can really handle it when it goes south, but I don't need to. I have that capability. So I walk into oh, this guy's stabbed, this guy's septic. It's fine.
You got that foundation. That's good.
Yeah, they'll never take that from me. So yeah. After meeting Ryan there, Ryan wisely got some good experience and moved on to a little bit less of an intense commute.
Greener pastures.
Yeah, greener pastures. And myself, like I said, I was there on a 2-year contract. So not a lot of people stayed around in that job, so they made me a charge nurse in under a year, which was my first shift I took as a charge nurse. The charge nurse turned to me about halfway through the night and said, "I gotta go. You're in charge." And just I sat in the chair. And that was my instructions, and I was like, "Great." I guess I answered the phone and talked to the fire department when they're mad. It was pretty insane. And then
when they're mad,
yeah. And then when my boss showed up in the morning, she's like, "Where's this person?" And I was like, they left, and they didn't really tell me why. And I've just been kind of sitting here trying to do this. I'm not sure what I'm doing. Can you help?
I'm going out to get a pack of smokes and some milk.
So yeah, just crazy stuff, man. It was. I look at it fondly. I guess I have kind of like rose-colored glasses.
I was gonna say in a weird retrospective.
Yeah,
yeah, exactly.
Now that I'm not there, it looks real great. But no, it was a valuable experience. There's not a lot of places that you can have that kind of level of critical care or be made a charge nurse in such a short period of time and run a department. It was good, and I did all night shift, I still do night shifts. It's a lot of fun.
We're all ex-night shifters.
Yeah.
There's something about us. We're just way cooler.
Yeah, so much cooler.
Right?
So much
Just
cooler.
Lay it back. We're cool as a cucumber with all the critical stuff. We're just, hey, that's just the way it is. We're used to like low personnel and not having a lot of help.
Yeah.
We're just
Yeah.
this is what we do.
Well, I'm a trader right now. I'm doing day shift for
Yeah.
at least through March.
Hurts
That's
my
when we're
heart.
cranky and
Hurts my heart, man.
You
That's right
know what it is? It's that big orange ball in the sky. It just makes everybody mad. Just think about the Middle East. It's all dry and hot, and the sun's always out. If it goes away, just ew.
Yeah.
No. Right? You never just say, oh, I hit traffic, or I couldn't find a parking spot. No. But everything is scarier at night. Just for everybody.
Yeah.
Just imagine when you were a kid and you were sick, and then like you woke up, there's nobody around, it's quiet,
Yeah.
you don't feel well, and you're like,
Something's up.
it's scary.
It's scary in the ER too, because like the ER doctor will go to the unit secretary and be like, "Can you give me the pediatric neurologist at night?" And they'll just start laughing. It's like, that's good luck. It's not gonna happen.
But hey, I wanted to ask you, what drew you to nursing though? Was it a lifestyle thing that worked with your wife going to med school, or was there something specific that drew you to nursing? That
It was the Lorna Dunes.
yeah, if there's someone out here listening and considering nursing,
Okay.
what drew you to it?
It's a lot. It's pretty much the whole package. Nursing is fantastic. It's a lot of. Let me put it this way. It's not something that a lot of guys think about like off the bat. Is like, I want to be a nurse, and that's a cultural shift that's changing, especially in the emergency department, because my emergency department now is, I think, 50 or 55% male. It's like right on the line, if not over it, which is great. In the ED, there's a lot more guys, nurses, and it's kind of like our idea of fun, I guess. Like, not that our girls aren't fun; they kick ass too. It's just it's a certain kind of mentality that's attracted to the chaos, that department, and I think guys tend to skew a little bit more often that way. But everybody in there is badass. But nursing, like, I knew I liked the lifestyle because I was already working there. Like I said, I overstayed my time as an EMT because I enjoyed working 3 days and having 4 days off. Like, next week, actually starting tomorrow, I'm working Friday, Saturday, Sunday, Monday. Then I'm off till the next week, and I'm working Thursday, Friday, Saturday. So boom, 8 days. Like, people kill for 8 days off. I have 8 days off for no reason. Like, I'm not even doing anything. I'm going to go to Big Bear and like snowboard, and like, I might end up picking up a shift if things are just like, if I get too bored, but that's an option,
Oh yeah, that's way too many days off.
Yeah.
That's
there's
true.
something about
After
that-
4, I
No,
started looking at my bank account.
There's something
I'm like,
about
do I
that
have to go
schedule
back?
that's so amazing. Like, I just did a shift trade, and now I have 10 days off next week. I'm like, this is awesome.
Yeah.
Like, all I have to do is like, I'll work a hard week, and then I get 10 days off. I'm going to a class, but it's whatever.
I mean, full disclosure, it was like originally we were going to go to a quick trip to Mexico because my wife has this time as a selective time on her residency, which means she's doing medical Spanish, which means a trip to Mexico kind of falls under that umbrella.
Nice.
But she's on what's called Jeopardy, which means that if somebody calls in sick, she has to be in the hospital in under 2 hours. So we can't go anywhere that's not 2 hours. And if you drive like a madman, you get to Big Bear. So we're gonna do
That works.
do that if we
You're
can.
gonna learn some. You have corazon pain.
The Lord?
Tiene dolor aquí.
Tienes un dollar?
Oh, and they just upped the amount we get paid for bilingual pay. I gotta learn Spanish, dude. I got to.
Spanish
Yes. Hola, ¿cómo está?
or Mandarin.
Me hablo Josiah.
Hola ese.
I still have that Spanish book you gave me.
Oh, do you?
I need to learn that shit.
Is the pop-up one, or is it the?
The pop-up one.
It's good.
It scares me though. When I flip the page, it just comes out at me. I just get startled.
But I think, Ryan, just to kind of close on your question, I
Yeah.
think the biggest thing that really attracted me to nursing, it wasn't the lifestyle or the money. It was really like the job itself, what you do, what you're doing every day, like the unending cap on knowledge, the unending cap on skills. Like, you can start ultrasound guided IVs.
Yeah.
You can go any direction with a career. If you get sick of something, you can jump into something else very easily. Not that I ever thought I'd really leave the ER, but it's nice to have the options open. And then just the connections that you get with the patients, or, your bedside. The doctor's not bedside for that long. The PA or NP isn't at bedside for that long. You're in there and you're treating them, and like, you have an ICU patient, you're in that room for hours. It's fantastic. You're the communicator, you're consoling, you're facilitator in high tense situations. Like it's just such an umbrella of skill sets, and I feel like I enjoy all of it. So that was really what drew me to it in the end, was the fact that I would spend my lifetime learning and that I would be doing a job that I found personally rewarding. And then the gravy on top of it was just the schedule, and it's a good living. It's not, there's no denying that. So when you look at that all as a package, you start to be like, this is the only thing I want to do now. I don't really have another thing that I could see myself doing.
Yeah.
So
I definitely feel the same way, especially as a paramedic on the rig. My version was like, if you've done everything once or twice, like strokes are about time, and then you have your algorithm for that. Traumas are an algorithm. A full arrest is the ACLS algorithm. And then I started wanting to know why.
Right.
And then like progressing from like, okay, what happens after we drop them off? And that's kind of how I felt in nursing.
It's fun too, because that never stops. Like eventually it's like you're getting off shift and your patient's going to the cath lab and you just go with them, and then you see what that side of medicine is.
Yeah,
and then
right.
You can go to like recovery and the floor, and it's fun now, having seen one of the things I did in nursing school that I really enjoyed was one day they gave us a patient, and it wasn't like a rotation, it was a patient. So I was there from the moment they came in for their like pre-screening for their surgery. I was there in the pre-op, through the surgery. I was in the PACU. Patient went to the floor. I took the patient on the floor. They were my patient on the floor for 2 days, and then they were discharged, and I helped with that process. So I saw the patient from intake to discharge, the surgery, every part of the process.
That's really cool.
It was really great. Like, it's not an experience that I think most nursing schools offer. So big ups to Santa Barbara City College. Good job, guys.
Nice.
Putting us through that. I enjoyed that very much.
Yeah, that's nice.
Yeah.
Yeah, I ended up teaching PHTLS at my old paramedic school. And I was just kind of shooting the shit with some of the guys, and there was, when we went through that same program, we had to do a lot more clinical hours than the typical paramedic school. So we got to go see pretty much every unit of a hospital. I mean, Ped ICU, ICU, Ped clinic, burn, OR, ortho,
L&D.
respiratory, L&D, OR, ER. So we kind of got to see the full gamut of the hospital, and that I thought that was such a cool experience. So when I was talking to them, they were like, "Oh yeah, we have our ER rotations and a couple OR, and that's it." I was like,
Did you say respiratory too? Because I think that's unique to our
I
program.
think that was, and burn was unique.
Yeah.
There's a lot, and we got to see all of it. And I thought that was such an interesting and unique experience, because you got to see what these patients go through after they go through our care. So like, some of those burn calls are some of the most intense calls, and then you get to go and see what they have to go through. So how important it really is to treat those patients as well as you can, and give proper turnover and what they're about to endure. And
their life is not going to be good for the next several months.
Months.
It's going to be a long road for them. Burns are some of my least favorite things to ever see. Like, that is probably the most acute pain I've seen anyone in, and that's through hip fractures and pretty much everything else you could imagine. Burns really strike a certain note with me.
So acute pain, and then it's also, for us, is the initial patient movement is very difficult. So you depending on how severe the burn is, you can't just pick them up like we do other patients and gently set them on the gurney, or if you pick them up, their skin's sloughing off and stuff. So you have to be very gentle and certain how you go about things, and it changes your whole game plan that you typically follow through with.
Yeah, it can be rough on you as a provider too, because I mean, I don't want to get too dark here. I mean, I guess it's right.
I'm going to lighten up in a second with a story that just popped into my head. So go ahead.
I just going to say, like, if you have a patient and they have a certain percentage body burn, you understand what their prognosis is. And it's very hard, because that patient is alive and in a lot of pain and talking to you, and you just know based on what percentage of them is burned, what the likely end scenario for this is. And it's not something that you like to entertain in the moment. So burns can be real hard to deal with on a lot of levels. And I mean, for me, it's just mostly like, okay, what the thing I want to do as a human being is control their pain, like that. And it was the Parkland burn formula. I don't know if you guys learned that in the field.
We implement it so little in the field. We learn it, but we implement a very small amount of it in the field,
Yeah, when in doubt, just flood them. If you're going to do a liter,
our big thing is pain control for sure.
Yeah.
So my last big burn, this young lady, she got some significant burns on her legs when she was working in a restaurant. She spilt some hot water on her legs. But as we were walking in, I was like, man, it really smells like hot dogs in here. And I was like, what is going on? It just reeks of hot dogs. And I walk in, and so I don't know if it's like a Hispanic culture thing or one of those old wives' tales in Latin communities or what, but this woman was getting her legs lathered in mustard.
Yes, I was gonna say it is
in mustard, and I was like,
mustard.
Yeah,
what the fuck is going on?
I have cleaned mustard off multiple burn patients.
Okay,
yes, so that is
that
not
was my
a unique
first time,
experience,
and
yeah.
I was like, what is happening? And this her coworker was just like working her legs like she was massaging her legs with mustard, and I was like, stop.
Yeah.
What are you
No,
doing?
Dijon.
Yeah, it was so weird. I had never seen it before, and I thought it was so funny.
You can tell they're
But I was
French
trying not- I was
Mexican
like-
because it's Grey Poupon.
Is that a thing you've heard, Mike?
No,
No,
I just assume you
No.
guys.
I've seen.
not mustard. Rubbing alcohol.
Because why?
Yeah, so I was like, okay, so we had to like clean it all off,
my
and like,
goodness.
but the woman, she was like rubbing it on, so she was like sloughing off skin and stuff. I was like, just
Oh, yeah.
oh, it was brutal, man. It was brutal.
Yeah.
So I just was like, you sit there. I shot her up with a bunch of drugs, and I was like, you
Skin
just
was coming
relax.
off, and you're like, is that sauerkraut?
Oh,
or is
it
that?
was-
Oh,
I told him,
gosh.
I said it smelled like hot dog, man. It was weird.
So
I got hungry after.
We went to Costco.
at my current ER, the demographic, a large portion of the demographic is Hispanic, and we had one potato peels for swelling. So they came in and like had like a mechanical fall or something,
Yeah.
and then they had this arm wrapped, almost compression wrapped, and the EMT was unwrapping it because you wanted to expose it right for the PA to see it, and then obviously you see this like potato peel like limp out of the thing. And he's like, "Wow, what is it?" He thought it was like skin or something, and they're like, "No, that's potato. We put it on for swelling." And this was all in Spanish, right? And then to their, they're like, "Oh, look, see, it went down." And then we're all looking like, "You don't think it was a compression bandage you put on there that put down the swelling?" It was really like the potato skin. I was like, so I learned that one too.
Yeah.
Interesting.
Potato skin for swelling,
Well,
mustard for burns.
it's not a thing.
Okay.
Don't do that.
But you should be aware of cultural treatments. That's like a big thing. Like,
Yeah.
and it starts to shock you in the beginning, but now when I see something, usually like there's never a judgment because people have very poor health literacy, especially in a lot of the areas that we've worked.
yeah.
Like very poor health literacy. Just engaging the patient. If you don't know what something is, just ask. Like,
Yeah.
what is this? Why did you do this? And they'll explain it to you, and then you can just kind of bank that. Like I remember we had a guy that wouldn't go to the cath lab for his raging STEMI with like 40 millimeters of elevation. This guy was making his own real tombstones, and all he wanted was what was it, like water with lemon and salt or something like that in it, and he was just like, I need this. This is the only thing I need. And we were like, no, you're NPO. You need to go to the cath lab right now. We can't give you anything. And he was just adamantly refusing. And finally, our charge nurse was like, if I give you this thing and you do not feel better in 5 minutes, will you let us take you to the cath lab? And he's like, yes. And she looks to the doctor, and the doctor's just nodding. And so runs, breaks into the cafeteria because it's 2 a.m. Gets a lemon, gets the salt, puts it in the water, gives it to the guy. He drinks it. He sits there for a minute. He's like, okay, take me. And then so it's
Jeez.
sometimes accommodation is the best way to the end
Yeah.
result that you need if you're getting into a situation like that. So
Sorry, that brings me back to my STEMI. I totally forgot to mention this. I was going to give another PSA. Was an old habit I used to always do, and I totally fell out of my normal treatment, is that anytime I had a STEMI, I'd put pads on, and just in case. And it'd been so long, I've ran so many STEMIs that nothing happened, that I've kind of gotten out of that practice. So I was like, why waste the pads? But with this last guy who coded right in front of me, who coded 2 minutes after getting off my gurney, it was one of those things like, I need to start doing that again, because you never know when they can just go into VFib and code on you, and then you're sitting there fuddle fucking with the pads. Just put them on just in case, and they're not your pads. You're not paying for them. Who cares? Just put them on. And it was one of those things. So I hadn't had a patient die in front of me in a long time. Like, it was one of those reminders. Like, hey, it's one of those practice things that when it happens, it will be very beneficial. So I definitely make that recommendation. Like, that's it is immediately implemented back into my practice. So it was one of those reminders. So
Yeah, you make a good point. Why not? You're not paying for them. Just throw them on.
Yeah.
Like people would be like, "Why did you open the atrium for the chest tube?" Like we don't even. I'm like, why? Because they're in a rollover TC and they're short of breath. Like I'm not gonna wait for chest X-ray. Let's just get things ready. Like
exactly right.
Yeah, like, it's not gonna hurt to set it up.
That's definitely standard procedure since we are a STEMI center.
Yeah.
But depending on, I guess it would just be your hospital's policy. If you are going to place the pads, you should probably place them augmented from the diagram because they don't want it to occlude is it the CT where they're ejecting dye or the X-ray? So you want to put it like higher, more like, what's that, right upper anterior chest, and then more lateral on the side. That way you're not occluding the CT.
Would they be opposed to front and back? 'Cause I know that is Zoll's recommendation for pad placement.
Anterior posterior will block the CT.
Yeah,
so
that's like mid-image.
Yeah.
I mean, a lot of those pads are radiolucent or not radiolucent, radio transparent for those like specific purposes, so you can X-ray through them, but like not all of them. And like a lot, I don't know how it is now with a lot of those ones that have like that. I don't know what the exact mechanism of it is called or the device is called, but the ones where like they have the big thing that helps you
The puck?
Yeah, where you can see the underlying rhythm through the compression.
See through CPR, yeah. So most Zoll products, so that's what we carry, has the puck on it, and that's it allows for the see-through CPR information. So,
I mean, our local department has that too. We have to take that off.
Yeah, you could just remove it for the CT. You're never going to CT somebody you're actively doing compressions on. I don't think a Lucas fits in there either. So,
that's a good point. So I was curious, was there a big mentality shift from EMT to nursing, or because you were in the hospital setting, did it kind of already flow pretty easily?
This is one of the things that I actually talk to people who are graduating because there's a huge track of people who are EMTs that work in the ER who become nurses, and you think you know what you're getting into. You think you know that because you've worked in this ER for 2, 3, whatever amount of years, and you've been there, you one-on-one with the nurses all the time, you're in the patient rooms, you think you have an idea. You have no idea. It's a very 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 different job. At the end of like my shifts, I would be tired from thinking, that was that was never like that as an EMT. Like, not to disparage any EMTs out there, you guys think about things, but as a nurse, it's a very, very different level of mental engagement. And the sense of responsibility that you have as having a patient be your patient is very different.
Oh yeah.
Like it is something that I was kind of unprepared for. And like, I didn't think I was like, hot shit on a stick coming in here. Like, oh, I'm going to do this. It's going to be so easy. Like, I knew there were going to be challenges, but that was one of the ones where I thought I was going to be comfortable and I was not. Becoming the primary nurse after being an EMT, no matter how long you're that EMT, it's just not the same job at all. Like, aspects of your EMT time that you will use as a nurse for sure. And that makes it great that you don't have to think about how to do a thumb spike, a splint, or a 12-lead EMT, or good wound care and dressings. And like, I can do a pressure dressing on a digit, like no problem. Like those are great as far as like documentation and nursing assessment and med management and understanding the pathology of your patient and what would be, like I talked about, flooding a CHF patient. Like those orders go in all the time. You need to know what to look out for and like things to reassess, and it's just this constant juggle. And you have 4 of them. As an EMT walking into the room to work with your patient, you're due addressing, like you said, task-oriented kind of stuff earlier. That is very much the difference. Like, you're still task-oriented as a nurse, but once you're done with the task, it doesn't stop there. There's a lot going on with that task. The reasons you did that task are now concerning to you, and the follow-up is important. So that was the biggest change.
Yeah. So I'm curious now, Ryan, did you have that same experience? Because you went from EMT to paramedic and then nurse. So I feel a very similar thought process as far as from going to EMT to paramedic, where there's so much more responsibility as far as that patient being yours, and you have to completely understand what's going on with them, compared to EMT, where you're more of an assistant. You have an idea, you have this concept of what's going on with patients as far as how to assess them, but when they give you certain information back, you're like, okay, I know how to convey that to the next provider, but I really don't know what that means or what kind of pathophysiology is occurring underneath that.
Right.
So do you kind of have that same experience as far as that's concerned?
So I like to say, like, going from medic to RN, there's definitely a lot of overlap in the curriculum and foundations. And like, I feel like what helped me was skills. Like I didn't have to worry about my IVs. You start lines, you give IM meds. We all learned that stuff in medic school. So I felt like my skills were okay. But charting like a nurse, thinking like a nurse, managing 4 patients. I remember like starting at RER. Like, I just felt like I got hit by a semi truck after after a shift, and I never had time to sit down. I thought all my patients were gonna die.
Kegels.
Yeah. But then it's just
your sphincter must be so tight.
And then prioritizing. For us, it's one patient at a time.
Slow down.
It's one patient at a time.
I know, right?
And then you had to prioritize based on acuity, and then you had 4 patients and they all needed meds, and you had to figure out which one was the most important one. And lab values, like another thing that I'm still guilty of from time to time, but it's usually benign stuff. But like as a medic, you identify chief complaint, you see if your ALS box can treat it. Like shortness of breath is the easy one, right?
Yeah.
Shortness of breath, you auscultate lung sounds, you give a breathing treatment, you go to the ER, hand off, done, right? Like you fix the problem. So you carry that over into nursing, like a sepsis patient. You fever, tachycardia, whatever, code sepsis alert, you give your fluids, your antibiotics, you draw lactate, it's like, 3.5. But then you're like, oh, I'm done. I gave everything, so he should be good. You forget to reassess. You forget to order those serial lactics, or if like a chest pain, you're like, oh yeah, well his troponin was 2.1 and that matches like his chest pain, and we gave him the nitro paste and the nitro and this, and you're like, okay. And then you're like, well, what was his repeat? Oh yeah, about that repeat, like so.
I got a repeat. Is he not better? Is he not gone?
Yeah. So like, there's the point of like EMS where you identify a problem, you stabilize, and you give him to the ER, and then as a nurse, you have to take over, and you're either continue that treatment, after the ER physician sees them, but then you have to remember to reevaluate. And I think that was the hardest part, was like you carry out these tasks, and you're like, oh, we fixed them, and then you're like, well, what about the repeats? What are the trends? And you're like, oh yeah.
I have nothing but the utmost appreciation for you guys in regards to that, because like I think there's certain components that we have in our job that is a little more difficult, and then other components where like, hey, we have it nice and easy. Like, it is difficult being out in the field, in the environment of whatever it may be, dealing with family and all that stuff, especially on critical calls where out where I work, it gets to be 120 degrees, families freaking out, screaming at you. Like, I remember that pediatric full arrest, mom was in my face screaming at me while I was trying to do compressions. And that's one of those like, difficult things that you have to deal with less. You have these nice lights and all this personnel and air conditioning, but that continuity of care, as far as like, I'm with them for 20 minutes. That's awesome. And after that, I'm done. Yeah. And I get to go home and get a workout in, or go back to the station, eat lunch, and I never have to think about it again. That patient might be in your yard. Like, if your ICU's full and they have to, what's it called when you have to stay in the ER?
Holding.
Yeah.
Holding the wall. What's up?
There you go. Hold it.
So if you're holding in the ER and you can't go to the ICU, that patient's yours, and that's an ICU patient. That's a difficult patient to deal with, and you have to be there with them for 12-hour shift. That's tough, man. I can't imagine having to deal with, oh, I want another blanket. And that's just the annoying ones. That's not the acute ones, right?
Sandwiches.
Oh,
yeah.
So
I'm hungry. I'm cold. You're like, you have 17 blankets on you, lady. There's literally no other blankets for you.
Can I get
entire
one of those
ER.
warm blankets? And you're like, blankets, you're warm because pretty much you warm it up.
You're
so
107 degrees. You need to take those off.
So I don't know if I can convey this thought and question, but did you ever work on an ambulance?
No, I never worked on an ambulance. So I've done several ride-alongs that were mostly uneventful, but that is really the limit.
Curse of the ride-along.
Yeah, I know.
Yeah,
I did get to go code 3 one time, which was fun, but it was like even in the moment. I think they just kind of almost did it for me.
It loses its luster.
It becomes annoying.
It becomes more annoying than anything. You're just like, get the fuck out of my way. Pull to the right. God damn it, everybody. Pull to the right and let me drive. And I'm like,
now you know why they turned off the PA on this thing. But
Yeah,
you can't
right?
access it.
I have done some critical care transports out of necessity, but I'll tell a good story about that in a minute. But go ahead with what you were trying to say.
Well, the other two knuckleheads over here. Would you agree, though, and I thought about this, when I started out, is the fact that when you said, EMT is pretty much you're an assistant, and you don't really realize it, but as a paramedic, I thought this. I go, you know what we really are? Just time brokers.
yes, I completely agree with that.
So as you're pretty much trying to get to the next provider, so them too. But when your time is up, your time is up. Doesn't matter how good a medic you have, the best in the world, best doctor, best cardiologist, best whatever. Your time is up. Your time is up. How do you feel about that? As far as for us, that's like you got to know your stuff. You got to know how to execute, and hopefully get into the hospital still alive, like Josiah said. So how does that, as being nurses, how does that make you feel? Like, do you feel you're kind of a time broker too when you're functioning as a nurse in the ER?
I think you have a good approach to it. When your time is up, your time is up. We are doing everything within our power to optimize your outcome. If the things we do, which are based on best practice and good evidence, don't save your life, that is sad, but it's not something that I feel overwhelming amounts of guilt on. You guys are also in a unique position out on the rigs in the field where you are kind of the sole responsible party for this person's life. Like you are the medic. It's you in the back and the EMT driving, and frequently it's a 1-to-1 kind of thing. And it's not like a 1-to-1 in the ER where I have, like other nurses that are there with me. I have an ER doctor I can call over to.
You're the highest medical authority.
Yes.
Imagine being in the ER with you're the nurse and then everybody else is the EMT. And you're like, fuck.
Yeah, it's a shorter window of time, but a much more intense level of responsibility, and with much less in way of resources than we have in an emergency department. That said, I think the expectations of what you can do are lower because you can't, dialyze someone. You can't, draw labs and treat whatever underlying condition. You can keep them alive, compressions, all these kinds of things. They're very, very important, but they're like acute emergency management to get the person to the hospital,
Yeah.
Like you have interventions you can do. You can intubate. I don't know what your protocols are in the areas that you've worked, but some places, you can
RSI.
Yeah. Depends. I mean, there's all kinds, like there's certain places you can do like a pigtail, like for pneumos and stuff like that. There's depending on how far you are from a city, like it's really varies wildly when you're in the county, but it's interesting, like to think about the dynamics that you guys have to experience that we don't, because we have that backup.
Yeah, I think we take for granted the fact that there's a lot of patients that we have that are not acute in a sense, but when they get to the ER, there's a lot that needs to be done, right? Those abdominal pains that we kind of take for granted. Oh, we just start an IV, we bring them in, and then they'll diagnose and treat from there. Or, some of these patients that we can't do a whole lot, so we don't look at them as those, oh my God, this is acute STEMI or stroke or whatever it may be, but require a lot of work in the emergency room. So
yeah, it's funny because I think that really for us, like it comes down to the differential and the workup. The workup's a really big part of our thing, and it's not so much. Like you guys are about the preservation and getting the patient to the emergency department and information gathering, really, like what is wrong, how long has it been wrong, like packaging a good story, giving a good handoff, keeping the patient, alive and well. And when we get there, we're diving right into this differential, like, oh, you have abdominal pain. Let's start with MI. Let's start with viral gastritis. We think about AAA. Let's think about ulcerative colitis. What do did somebody hit you in the stomach? Like this thing goes forever, you know, like it just never stops. Good abdominal pain story. We had a guy come in. He was a trauma, and he had been in a car accident. And he had like the seatbelt sign and all that kind of stuff. And the doctor was like palpating his abdomen just as part of the assessment. He kept groaning in the lower right quadrant. And he's like, "What's going on?" And one of the nurses like, "Watch him have a nappy." Totally had a nappy. So,
oh, really?
Yeah.
No way.
Yeah, as just an incidental. Like we took his temperature. His fever was like 103. He was like, "Wow, he's in a car accident. A 103 fever."
That's just bad luck.
Yeah.
Sorry, you're an accident. You also have appendicitis.
Yeah. So there's so many curveballs out there. Like how could you guys catch all that kind of stuff? There's just no way, So those are the kind of filters that get turned on when you get to the emergency department, and it's just a different animal. Again, that's why I was kind of attracted to it. I liked seeing all this part and this side of medicine. I really enjoyed that. And I don't think there's a wrong answer for anyone who's out there looking to try and get into this field, and depending on your background, where you want to go. Brian is living proof that it's easy to go from, well, maybe not easy. I don't want to say easy, but you can go from paramedic to nursing and vice versa. It's a flexible field, and the skills translate well from one place to another. Maybe there's different emphases on different syllables, but we definitely,
definitely,
hit it.
Yeah, but we all are involved in the same game.
Just for my curiosity's sake, having increased your knowledge base, Has that ever given you luster to increase it again? I know you have a wife that's med
so
school.
I'm in the throes of a terrible internal struggle deciding what I want to do my master's in.
Yeah.
So I really, for a long time, thought I wanted to jump right into my NP after finishing my bachelor's. But I really enjoy education. So I did for a while I was working as an EMT in the hospital in Santa Barbara. I also TA'd as an EMT instructor, just doing the lab stuff, like walking people through C-spine. And my original degree was English because I was going to teach. And I feel like a lot of us are kind of second career junkies. Like we did something and I'm like, why'd I do that? I should do something else.
I was a gigolo before this.
There you go. So, yeah,
I knew it. That mustache.
You gave it up?
Now it's the womb room. What do you want?
And that really was something that I loved doing. And now, as you know, I've been in the emergency department now for 14 years, something along those lines. And I love it. I still love going to work, but I know in 10, 15 years, I'll still want to work, but I probably won't want to be doing high intensity ER shift just because it's rough. It's a physically demanding thing. Like we said, Kegels, man. I can't do that for 12 and a half hours a day in my late 50s, early 60s. Some people can. I don't know if I will. So I think teaching is a great way to take your experience and pass it forward. And I'm passionate about education. I love yelling at people in Whole Foods about vaccinations. Like
I went on a rant last episode about that. I was just like,
do you just go just for that? Like,
oh yeah,
I need an avocado. I could have got it cheap
No,
in the
dude, I don't
market, but I just go over there to hassle people.
I don't need anything. I wander around listening for it, like checking kids for chicken pox. You know,
knew what's gonna come up. All right.
You know, I was going to tell you because, like, I didn't know that you majored in English and that you might want to teach. But there's a nurse that reminds me a lot like you at my ER.
Mm-hmm.
And he's in a critical care NP program that I guess UCLA is one of the few that offers it.
Mm-hmm.
And I thought that would be a good one for you because that was like you'd be the NP for the trauma intensivist. So
right.
His rotations consisted of, like, suturing, cardiothoracic surgery, neuro ICU, and, like, it seemed very interesting, but it was very definitely content heavy. Like,
yeah, that's so. As I talk to more people and dive deeper into like what it entails to be different kinds of NPs, because they're so specific, and certain hospitals only want certain kinds of NPs. It's very difficult to pin down exactly what you want to end up doing for life. You know, because like it's a little bit more difficult as an NP, not like a nurse. You're more specialized. If you're going to do primary care, if you do critical care, you can now see critical care patients, but you can't see peds. You know, it depends on the kinds of programs that you want to do. Or you could just take it like, you know, I could do, if I wanted to see like, you know, family NP, do that program, then maybe I'd want to teach NP program. That was something that crossed my mind. Do it not in so much to do it as a career, but do it so that I could teach the program. That would be fun too. Then I could kind of combine both worlds. Do I want to do a master's in education and then master's in nurse practitioning? And then I don't know if I'll be alive that long. Like, we'll see where I end up with things. So,
yeah.
But it's nice because I'm debating between good options. This is no longer like me struggling. Like, what do I want to do with my life?
It's so good to be in this position,
yes,
right? It was a long road of struggle, and now you're like, okay, now I have a bunch of options. I'm living comfortably. Like,
yeah,
what else do I want to do? I love education. I've taught for 5 years, like ACLS and PALS to nursing schools and paramedics and stuff. And now I'm learning I'm getting certified for PHTLS instruction, which is the trauma pre-hospital life support. But it's fun. It's really fun. Just it keeps you tuned in and like on point as far as all your skills in education, because you want to be able to describe everything and explain everything.
Right.
But
you're responsible for that knowledge.
Yeah.
That's a heavy thing.
Yeah. And you don't know what kind of bizarre questions will pop up. And you're like, fuck, I've never thought about that before. I'm like, let me.
and that, I think, is where I differentiate good instructors from bad instructors, because a good instructor will be like, that is an excellent question. I have absolutely no idea. Let's look that up together, or I'll get back to you with the answer. And a bad instructor will be like, I think, and then they'll just go on a tangent.
Bullshit.
Yeah, completely. You can smell it. Like,
bad instructor goes, please quit interrupting. I raised my hand.
Wait, so we're already well over an hour, so
nice.
I know time kind of flew by, but
before,
thank you so much for coming.
Yeah,
hold on, before we end though, maybe an opportunity here.
Yeah.
As far as sponsors go, we have a slot for I need 7 hours of CEs or something for my state medic. So to anybody, one of those companies that do online stuff, want to pop in. Just
also, Doers, we drink you every podcast, so I feel like you should sponsor us. But Hey, thank you so much for coming on. I really appreciate it. Love the stories. Love learning a little more
yeah.
about you and the nursing world. And
It was my pleasure, man. Thanks for having me.
Thank you.
yeah.
And via con Dios.
All right. Thank you for listening to Holding the Wall.
Like I said, YouTube, Instagram, or iTunes.
Feel free to contact us at holdingthewall@gmail.com or DM us at Instagram at holdingthewall.
Thank you to our sponsors and support us on Patreon for extra content. Hope to see you soon. Toodaloo, motherfuckers.